Hi, my name is Dorothee Oberdhan. I'm the Director for Patient-Centered Outcomes at Otsuka in the Global Value and Real-World Evidence Group. And I'm going to be talking about clinical outcome assessment in ADPKD. So as a disclaimer, the views and opinions expressed in the following PowerPoint slides are those of the individual presenter, me, and should not be attributed to Otsuka. So to set first, the topic of patient experience data in clinical trials is gaining in importance. And I would like to review kind of what we understand under the expression of patient experience. So patient experience means that it helps to understand patient perspective on benefit and risks. We do that by looking at clinical outcomes by using clinical outcome assessments, COAs, that describe how a patient feels, functions, or survives in a way that is relevant to the patient in the context of the disease. And we use it to evaluate clinical benefit by looking at how meaningful the effect of an intervention is on how a patient feels, functions, or survives. Patient experience includes things, for example, like disease symptoms, disease impacts, disease burden, preferences, and also treatment burden. And one way to look at that is asking patients on how they feel by using COAs. COAs are used to measure effects or attitudes related to a disease, condition, or treatment via structured questionnaires or diaries. And patient report outcomes, PROs, are a type of COA that is collected directly from the patient. Most frequently, we use PROs to look at symptoms or symptom burden by looking at absence or presence of symptoms, severity or frequency of symptoms, or all of these. We also use PROs to look at health-related quality of life by asking patients about their well-being, the impact, and function. Why do we collect COA data in ADPKD trials? There's different reasons why we would want to do that. We can use COA to describe the disease burden, to characterize the population, to look at disease impact over time and across disease stages. We also can use COAs to assess impact of an intervention, assess treatment impact over time and across disease stages, and to look at assessing lack of detrimental effect of a treatment. So there are also several challenges for COAs in ADPKD. First of all, it's a slowly progressing disease. There's also a lot of heterogeneity of symptoms across the population and disease spectrum. We need to ask ourselves if the COA measures concepts that can be impacted by the treatment, whether a meaningful change can be observed within the clinical trial duration, and if the measured concepts are applicable to the entire trial population. When we select a COA for a clinical trial, there are certain rules of thumb that we need to consider. First of all, it's that we need to look at the content validity. And that means that we need to understand if the questions in the questionnaire capture experiences that are relevant from a patient perspective. For example, if they're relevant to the disease stage and if there's a cultural fit for the population that you hope to enroll in your clinical trial. We also need to look at the reliability of the questionnaire. Are the scores consistent when measured under similar circumstances, for example? Also, we need to understand the responsiveness. Do the scores demonstrate a change? We also need to look at the feasibility. Is it easy to measure? Does the questionnaire require special expertise, special equipment, or what is the time that is required to complete the questionnaire? We need to look at if this questionnaire is applicable across the different settings, for example, a hospital versus community setting, or also different locations used in the trial. Is it available in different settings? For example, is the questionnaire available in different language versions that would be needed in the locations where the trial is conducted? And do we know if some validation has been done for the questionnaire in certain countries of interest? We also need to look at the acceptability of the questionnaire. So is it easy to understand and interpret the results? When we look at COAs and PROs, it's important to also look at it from a multi-stakeholder perspective. And you can look at COA from the patient perspective, clinician perspective, regulator, and payer perspective. And I'm going to start with the patient perspective here. So when a patient participates in a clinical trial and receives a treatment, really from the patient perspective, you need to ask yourself, is the treatment going to help me live better and function better, and am I going to live longer? What side effects will I have, and how will those impact my life and the ability to receive continued treatment? A lot of the patients will, for example, also be worried about, will my insurance cover this treatment when I need it? Are the questions and response options in this questionnaire that I'm being asked to complete, is this relevant to me in my situation? Does the questionnaire reflect what is important to me? Why those two are specifically important, like if the questions are totally irrelevant to the patient and their situation, they may not be motivated to complete the entire questionnaire. So you may end up with more missing data if it's not applicable. They may refuse to complete the questionnaire, or they're just going to rush through just to get it over with because they feel they're not going to be able to share relevant information. And it's just a checkbox exercise. From the clinician perspective, they're going to be wondering, it's like, is my patient going to be doing better with this treatment? How is my patient impacted by this treatment? And will the insurance cover this treatment for my patients who need it? How difficult is it going to be to prescribe the treatment? And when you specifically looked at the COA data, what does a change in the score actually mean? And will I be able to use this in my clinical practice if it's something relevant to the disease and to the patient? From a regulatory perspective, some of the typical questions would be like, is the treatment safe and effective? Is the benefit worth the risk? Do the trial data describe clinically meaningful within patient change? Is it reflected in the responder definition? And do patients have better quality of life and improved function? And then finally, from the payer perspective, the question is, should we cover this treatment? Is the cost worth the benefit? Are outcomes patient relevant and patient-centric? And do the trial data describe clinically meaningful differences using a fit-for-purpose instrument? What is the clinically meaningful impact on the covered population? And do patients have a better quality of life? Do they have improved function, participation in work and society settings? So we can see that these are quite different questions depending on what stakeholder you consider. But you can also tell that there is actually a connection between all of these. The patient wants the treatment, the clinician wants to be able to prescribe it, the regulator wants to make sure that there is a safe and effective treatment available for these patients, and the payer wants to make sure that they minimize their cost and the exposure and can still provide a treatment that is going to be useful for their covered population. And bringing all this together means that when we select the right COA and use it in the right way in the clinical trial, we might be able to generate data that meets the needs of all of these different stakeholders. It helps us get the treatment to the patients who need it, and that they actually can access these treatments that are going to help them live a better life. So there have been several efforts ongoing to define core use and quality of life and important outcomes for ADPKD patients. One of these efforts is the PKD Initiatives, and they have put together a core outcome set. And several of these core outcomes that have been identified by PKD are actually COAs or can be measured by using COAs. And first of all, here is in that core outcome, the critically important outcomes that are important to all stakeholder groups that should be reported in all trials. This includes cyst pain. Cyst pain is something that was endorsed by all the stakeholders and is something that is of high importance in ADPKD. And in the middle tier with the critically important outcomes that are relevant to some of the stakeholders, you have things like depression, fatigue, financial impact, impact on family and friends, but also physical function and strength. All of these are also important to most stakeholders, and especially was reflected by a lot of the patient population that participated. But there are also some shortcomings here with this model that Song PKD has come up with, because they actually haven't identified yet if there's any particular tools that should be used to assess some of these important outcomes. So what my team has done is that we undertook a large research project to look at obtaining patient insights on living with ADPKD and what the challenges are associated with that. So we interviewed 317 adult patients and 33 adolescent patients across 18 countries to find out what is important to this population, what should we be measuring, and how can we characterize the disease burden in ADPKD patients. We, as a result, we came up with a number of different ADPKD specific quality of life questionnaires and have administered those to over 1,500 patients across several studies to find out kind of how we can describe the disease burden in ADPKD patients and maybe even use this to assess treatment burden and quality of life in our clinical trials. And overall, our findings were that the disease-specific patient questionnaires will help to increase understanding of the burden disease across the entire spectrum of ADPKD. And here's an overview of our findings from this project. So we found that there is generally a lack of content validity when we use existing generic questionnaires like the SF36, the SF12, EQ5D, and the brief pain in. And that is because these generic questionnaires, they don't address a lot of the issues that are relevant to ADPKD patients. However, they do assess some issues that are irrelevant or meaningless. Existing kidney disease questionnaires are mostly focused on issues of the ESRD population and really don't address earlier disease stages of ADPKD at all. ADPKD patients have early physical and emotional impact due to uncertainty related to disease progression, kidney growth, and other symptoms. We also learned that ADPKD patients have underlying urinary issues related to urgency, frequency, urination, and nocturia. ADPKD patients also experience 3 distinct types of pain that are described as sharp, dull, and discomfort, and that is impacting their physical and emotional function. And adolescents with ADPKD actually reported a similar disease experience than adults. So here's one of the scales that we came up with, and we call it the ADPKD impact scale. So you can see that there are 3 different domains that we were able to classify these concepts into. And the physical domain includes things like engaging in leisure activities, being able to complete a full day's work or job at your job or at home. Also conduct daily activities as usual, regardless of pain, complete everything in a day due to tiredness or exhaustion, performing intense physical activities, modify lifestyle due to pain or discomfort, and being bothered by pain. So you can see here a reflection of what the SONG initiative found, that pain is very central to this disease experience. In the fatigue domain, it's all about exhaustion or fatigue, feeling tired while driving and feeling fatigued after a good night's sleep. And then finally, the emotional domain, where we have acceptance, anxiety, and sadness, but also feeling full before the appetite is being satisfied. So it's more likely that social experience where people feel that they cannot really fully participate. So, and then one big part of our findings kind of relates to pain, and we really found that there is a very complex pain experience in ADPKD. And the scale that we developed is the ADPKD Pain and Discomfort Scale, ADPKD PDS. And as I mentioned, there are 3 different types of pain that patients endorsed in our focus groups. And the first one is we describe as discomfort and fullness. And that is really present throughout the entire disease process. And it's a chronic type of pain that is mainly expressed as a sort of internal pressure on the organs. And there's just the general feeling with these patients that something isn't just right, but they're not quite sure if they should describe it as pain or something else, but it's that internal pressure, and they felt that it should really belong into this pain concept overall. It's related to that. And this chronic internal pressure for the patients, it does impact their quality of life, their daily function, and the ability to eat a full meal. But they're really unlikely to mention it to their healthcare provider because they don't quite know how to describe it. Then the second type of pain is described as dull kidney pain, and that also is a chronic type of pain that is described as a constant background pain in the lower back, abdomen, and the sides. This also, because it's of its chronic nature, it does impact the patient's quality of life, their activities of daily living and function. Patients tend to use pain medication when needed, and they're likely to mention this type of pain to their healthcare provider. And then finally, we have the severe, or sometimes also described as sharp kidney pain. That is a rare event for ADPKD patients. It's quite acute, but it's highly painful. And those events tend to be associated with cyst ruptures or infection and hematuria. The pain experience is described as being its absolute impact on quality of life and daily activities. Patients tend to end up in the hospital, and it's not uncommon for patients to receive a prescription of opioids for this type of pain. But this kind of also gets to the point, you need to make sure that you actually can assess this within the trial timeframe. But because it is so rare an event, and not every patient is going to be experiencing this, so that is one of the considerations that you need to look at, that the recall period, even of the questionnaire, might not capture these specific pain events if it doesn't fall in that period that you're asking about. You may also have patients that don't experience this type of pain during the entire trial. Here's an overview of our findings from the research with the adolescent patients, where we found that adolescents with rapidly progressing ADPKD also experienced the early symptoms and impacts on health-related quality of life. So when it comes to symptom reports, that was very consistent what we also heard from the adult patients, where even for the pain experience, it's very consistently described as having the back pain, intense pain, and also that discomfort concept was endorsed by the adolescents. But you can also see that they have high degree of urinary issues with the urgency, frequency, and nocturia. Patients report issues with their abdomen shape, size, fullness falls in here, and then also hypertension and hematuria. And the impacts that were reported by the adolescents are also quite consistent with what we saw from the adults. So then finally, we had a large study in several thousand patients from an observational study, the Overture study, where we used PRO instruments to look at the quality of life of ADPKD patients enrolled in this study, and then looked at what happens to patients that have generally good quality of life versus patients that have more poor quality of life outcomes. And how does that compare to the typical ADPKD outcomes that we see reported in clinical trials? For example, albuminuria, anemia, hypertension, hematuria, etc. And we found that overall, there were some key outcomes that were highly associated with poor quality of life reports. And really it stands out here that patients overwhelmingly that have poor quality of life also report kidney pain. So as a takeaway from our learnings here, so the use of course in ADPKD trials is a good way to obtain additional context on the disease and treatment experience from a patient perspective. Use, of course, can be challenging due to the slowly progressing nature of the disease and heterogeneity of symptoms. And specifically when it comes to ADPKD, sorry, I need to start again. So the takeaway from this research is that the use of course in ADPKD trials is a good way to obtain additional context on the disease and treatment experience from a patient perspective. Use of course can be challenging due to the slowly progressing nature of the disease and heterogeneity of symptoms. And specifically when it comes to ADPKD related pain, we learned that it really impacts patients across all CKD stages. It starts early in life. It can be associated with key disease features, for example, cyst growth and kidney volume. And because of the unclear conceptualization of pain, it really has led to inconsistent measurement of pain across studies. And when we try to compare this even across our own clinical trial program, we weren't able to look at that. And it really becomes apparent that by asking inconsistent questions, you really lose the ability to compare over time and get a better picture of how your treatment impacts pain experience in your population. Thank you.